Hi everyone. My name is Urin. I'm from the Levings Lab at UBC Vancouver. Today it's my pleasure to introduce Dr. Humar. Dr. Humar is a professor in the Department of Medicine of University of Toronto. He received his medical degree from the University of Ottawa and then went on to complete his residency and further training in transplant infectious diseases in Toronto and Boston. Dr. Humar's research interests are in virology with a focus on the pathogenesis of herpesvirus infections post-transplant. He is involved in both basic and clinical research, assessing immunologic and virologic determinants of infection. Dr. Humar is the director of multi-organ transplant program at the University Health Network and the University of Toronto Transplant Institute. Please join me in welcoming Dr. Humar today. Thank you.
Thank you. So I hope everyone can hear me. I will be talking about trials using infected donors, and I just want to acknowledge the CDTRP for inviting me to this webinar and for supporting much of this research. These are my conflict of interests. So if you think about a potentially infected donor, I'll just start off with some background before discussing some of the research that's going on through this CDTRP. If you talk about a potentially infected donor, it can be either with a known pathogen or an unknown pathogen. And I will be focusing on the known pathogens, but the common ones that we think about are the behavioral risk factor viruses, so-called, and that includes HIV, hepatitis C, and hepatitis B. Bacterial infections are very commonly transmitted through donation and transplantation. I'm not going to be talking any further about those. And then CMV and EBV are very commonly transmitted through organ transplantation, and as you all know, result in pretty significant morbidity and occasional mortality. So I'm going to focus on hepatitis C, CMV, and EBV as we think about trials related to infected donors and using infected organs that we knowingly transmit an infection to a recipient. Just to review the current donor testing that's done in Canada. So the first step is screening by history. The second step is a laboratory assay. So typically the HIV antibody assay is actually an antibody antigen assay. We do hepatitis B surface antigen and core antibody, and hepatitis C serology, as well as syphilis, CMV, and HTLV1 testing, as well as cultures. And then depending on where you live in Canada to some extent, and the type of donor that you have, we would do NAT testing or nucleic acid amplification testing, where you're directly looking for viremia, and that's commonly done for HIV, hepatitis C, and hepatitis B virus, as well as seasonally done for West Nile virus. So this was a study done through, at that time it was called the CNTRP, and it was looking at, in Ontario, the database of increased risk donors. So these are donors with behavioral risk factors for transmission of HIV, hepatitis C, or hepatitis B. So for example, IV drug users, commercial sex trade workers, or prison inmates, or other potential exposures to those pathogens. So this was data from 2015 to 2017. So it was a few years ago, 2013 to 2015. And you can see out of almost 500 potential donors, a pretty substantial number were IRDs. So almost 20% were classified as increased risk donors. And at that time, so this is now 3 to 5 years ago, there was only a 59% organ utilization from those donors. And then in follow-up to that, we also did a cross-Canada survey through the CNTRP network of looking at how often people were saying yes or no to those types of donors. And you can see, if you just look at, if you only did serology, that's in green, you can see the acceptance rate was anywhere from about 10 to 30%, depending on the risk factor of the donor. But if you did serology plus NAT testing, the acceptance rate increased to about 40 to 50%, which is still not that great. And I think now with a lot of the knowledge translation and education, and a lot of that has actually been spearheaded by CDTRP, but also by CST and others, I think the utilization rates are probably closer to 70 to 80% or maybe even higher. So what about the Hep C positive donors? So there's two types of donors here. So one would be antibody positive and NAT positive, and the second type of Hep C positive donor would be antibody positive but NAT negative. And I'm going to talk about clinical trials using the first set of donors, the NAT positive donors. Just briefly in terms of the NAT negative but antibody positive donors, we think it's probably safe to use those donors, and I'll just show some data in the next couple of slides. Before that though, if we want to get an idea of how common these donors are, they're very, very common. We don't have great Canadian data, but this is US data. And this shows the percentage of OPOs in the US where the donor was due to an overdose death. An opioid overdose death. So in 2000, it was 1% of donors, but in 2016, it was 15% of donors. And a good number of those opioid death donors are Hep C positive. So it's estimated that some of these OPOs, depending on the jurisdiction, about up to 20% of their donors might be hepatitis C positive. And if we added all these Hep C positive donors into the pool, that would be about 1,000 new donors in North America each year. So if you're antibody positive, NAT negative, is there a risk of transmission? And basically, we think that for non-liver organs, there is really no risk of transmission unless you've had a very recent clearance of the virus. So these patients behave most like the regular IRD patients and can be safely used for the most part. The exception though is liver transplant, where there does appear to be a 10% risk of transmission even if you're NAT negative. And this is based on a couple of studies. The largest one is this one that looked at 55 NAT negative antibody positive Hep C transplants where there was a 9% risk of transmission. So there does, even in patients who clear viremia, there does seem to be some residual virus left over in the liver that can subsequently transmit if you do a organ transplant, a liver transplant specifically. So what about the NAT positive donor, so HCV NAT positive donor? So here what you should do is assume 100% risk of transmission. And it is almost all the studies that have at least been presented or published do show that if you're NAT positive, there is 100% risk of transmission, regardless of what organ you use. But the rationale behind using these organs is that the current treatment regimens are well tolerated. They're usually a pill or 2 pills a day for 4 to 12 weeks. They're close to 100% effective, not quite 100%. They're pan-genotypic, so they work against all the genotypes of hepatitis C. And there's been a few studies published recently, as well as several that have been presented, and I'm going to show you the study that we did. And it was initially it was focused on lung transplant patients, and we've since expanded it to all the organ types. And this was lung transplantation using NAT positive donors to NAT negative recipients. And this was the study flow. So we used Hep C NAT positive donors. We did do ex vivo on these lungs with the idea that we could potentially at least, not to eliminate the virus, but at least kind of decrease the infectious inoculum. And then we transplanted them into NAT negative recipients. We did weekly PCR. And as soon as they became positive, once they had 2 positives in a row, we treated with Epclusa, which is a commonly used pan-genotypic Hep C regimen. And the typical treatment with that is one pill a day of Epclusa for 12 weeks. And so you can see between over a 13-month period, so October to 2017, November 2018, we did 209 lung transplants total, of which 22 were Hep C NAT positive. So it was about 10% of our activity was NAT positive donors. And this just shows the donor characteristics. So the control group is the 187 transplants from NAT negative donors, and the treatment group is the NAT positive 22 transplants. And I just want to point out here that the age of the donor, you'll notice, is much lower for the Hep C organs, and this has been shown in other studies too. So these organs are actually generally better than the non-Hep C positive organs. And the reason is that almost all of these are young IV drug users who have hepatitis C. You can see we also got a lot of these organs from the United States because they weren't using them. The overall other parameters were pretty similar. This is the recipient characteristics, and they were all pretty comparable for the most part. What was interesting is that even a lot of our older recipients didn't have a problem in terms of consenting for hepatitis C positive organs. In fact, they were quite open to it. And in many cases, it was our younger potential recipients who didn't feel comfortable getting a hepatitis C positive organ. The rest of it was all pretty comparable, except we did a few more single lung transplants with the Hep C organs because many of these were ILD patients who could get, or COPD patients who could get a single lung transplant. The other interesting thing is if you look at the median wait time, if you agree to get a Hep C positive organ, you generally end up getting an organ sooner. So the median wait time for an organ was only 17 days for those who agreed to get a Hep C positive organ. And these are the recipient outcomes versus again, the controls is the 187 versus the 22. And you can see that all the outcomes were essentially comparable. The average ICU stay was 4 days, and the hospital stay was on average 30 days. And overall, the outcomes were very good. The 90-day mortality was basically 4%. It was 2 patients who died of unrelated causes. So one was due to severe graft dysfunction, and the other was due to infection and sepsis. And this just shows the survival out to a little past 1 year for the controls and the Hep C, and you can see the long-term outcomes here were actually quite excellent for these patients. Now, in terms of what happened to these patients and their hepatitis C, so I'll just go through that. And so we had 22 patients, and 20 out of those 22 got infected. So the virus was detected within 7 days in all 20 of those patients, and 2 did not actually get infected. And I'll talk a little bit more about those 2 patients further in my talk. And then these 20 initiated antiviral treatment, and we actually waited. We waited till they were out of the ICU, and we waited till they could take pills orally rather than through an NG tube. So the median start time was actually 21 days after transplantation. And basically by month 1 of treatment, all of them were PCR negative, and all of them were negative at the end of treatment. But after treatment, we did have 2 relapses within 3 months. And this is actually a much higher relapse rate than has been reported in non-transplant patients, because 2 out of 20 is about 10% versus the normal relapse rate reported is about 1 or 2%. Both of these patients got retreated with a slightly different regimen, and both responded quite well to that. And this just shows the viral load. So on the x-axis is the days after transplant, and the y-axis is the log viral load. And you can see the viral load does become positive pretty early post-transplant and rises relatively quickly. So you're at about 4 logs by day 7 after transplant. And then once you start treatment here at day 21, you can see it goes down quite nicely. Now, the other thing that we were doing with this study is that we wanted to know if there was a way to even decrease the viral load further while the organ was on ex vivo, not necessarily to eliminate the virus, but to decrease it further. And one option is we thought of was using UV light, and UV light has been used a lot in the past for sterilization of blood products. So we thought having a UV customized illumination device that delivered UV in the perfusion circuit could at least sterilize the circulating virus that's in the graft. So this would only be applicable to non-liver grafts because you'd expect there to be no replication in the non-liver grafts. And here you can see this is the UV circuit right here. And the perfusate just goes through that circuit, and it kind of you kind of blast it with UV light, and then comes out of the circuit and goes back into the lungs. And this was data, in vitro data, looking at how this would inactivate hep C, and it just shows the in a mock circuit where you have virus and you deliver UV, it decreases. On the left-hand side is the PCR result, and you can see it decreases the amount of virus by PCR after 180 minutes of UV, but it's not terribly impressive. It only goes from 150,000 to 50,000. But if you look at infectivity, which you measure by doing a culture, you can actually show that after 150 minutes in the UV group, there's no infectivity. So what happens is you're breaking up the virus and you're still detecting it by PCR, but actually there's no infectivity. And so we've actually done in the patient data, I don't have all the data, but in the patients, those 22 patients, 10 of them actually got UVC in the circuit, in the ex vivo circuit. And the 2 that did not transmit hep C were both in the UV group. So the transmission rate was 80% in the UV group versus 100% in the non-UV group. So that looked potentially interesting. And the other thing we noticed is that the viral loads were much lower in the first 7 days in the patients that got the UV lungs. So the next phase of this study is actually to do this UV, but then do it in conjunction with delivering a much shorter course of antivirals and starting the antivirals right away post-transplant, rather than waiting 3 weeks post-transplant. We think if we start right away, plus if we give the UV, we can get away with a really, really short course of antivirals, which would be very attractive. So that study's ongoing, so more to come on that. So now I'm going to shift gears a little bit and talk about EBV and CMV, and these are slightly more challenging to treat, because these viruses are not, you would not expect them to be replicating in the lung. You'd expect them to be latent, and both of them are herpesvirus, so you'd expect them to be intranuclear within various residential cells within the lung, or the other, or whatever organ you use. I'm just going to use lung as the example here. Intranuclear but episomal. And for EBV, they would be primarily in B cells, and for CMV, it would probably be in multiple cell types, but the monocyte cell fraction, and possibly endothelial cells and other cell types as well. I'm going to talk about 3 kind of approaches that we've been looking at. So the first is for EBV, and it's using rituximab to target EBV. The second is, second 2 approaches are for CMV, and one is a CRISPR-based approach, and one is something called a fusion toxin protein, which I'll describe both of those in a little bit more detail. So first, the rituximab approach. So the idea here is that as you all know, rituximab is a monoclonal antibody that targets CD20, which is found on the surface of all B cells. ABV it lies latent in B cells, and rituximab, by binding to the CD20 receptor, results in antibody-dependent cell-mediated cytotoxicity, as well as complement-dependent cytotoxicity, leading to phagocytosis and induction of apoptosis of B cells. So the hypothesis here was that if we gave rituximab ex vivo, we could potentially deplete B cells and decrease the reservoir of latent EBV in the graft. And this would have implications if you were doing a donor positive, recipient negative EBV transplant. And as you know, those patients are at very high risk for developing PTLD. And if you could decrease the risk of PTLD by removing EBV, latent EBV from the graft, it would be a pretty significant advance. And the other thought we had is that because we're giving the drug ex vivo, it allows you to deliver a high dose locally, a higher dose than you would normally give. And it also decreases the potential for systemic cytotoxicity of the drug. The other important thing to remember is that against these viruses, if they're in a latent form, traditional antivirals like ganciclovir or acyclovir would not be active because those antivirals are only active against actively replicating viruses. So the study design for this is that, now this is a preclinical study, so we didn't transplant these lungs, but what we took was clinically rejected human donor lungs. So these were lungs that for whatever reason were not suitable for transplant. And then we put all the lungs on ex vivo, and we gave them either placebo or we gave them 500 milligram dose of rituximab, which is a pretty high local dose of rituximab. And that was delivered into the reservoir and perfused through the lungs for on average 6 hours or so. We tried to go for as long as possible, but these lungs were not in great shape to begin with because they were kind of declined lungs. So we tried to go for at least 6 hours, but up to 9 hours if possible. And then we collected perfusate, we collected lymph nodes, and we collected tissue biopsies pre and post perfusion with rituximab. And then what we did was, initially what we did flow cytometry on the tissue and on the lymph nodes for CD20 cells, so which is the B cell marker. And here what we do is, this graph compares a ratio of post versus pre perfusion CD20 cells by flow cytometry. And on the blue is the control, so it's 6 control lungs, and the red is the rituximab. And you can see there's a pretty nice reduction in the number of B cells within the graft, both in the lymph nodes within the graft as well as in the lung tissue. So we were pretty excited by this data that we could show that the rituximab is actually getting there, it's actually binding, and we can show that by flow at least there's a reduction in the number of B cells. And then what we did, we also looked at it by a tissue staining, and this is a lymph node that's stained for CD20, and you can see, well, it's not easy to see, but you can see that basically the brown is CD20 here, and you can see if you look at the amount of brown pre, you can see there's much less brown post perfusion, which was also pretty neat to see. And then what we thought is that, like, you wouldn't actually expect the rituximab to completely do its work within the 6 hours of ex vivo, but that doesn't necessarily matter. Like, as long as the rituximab's there and in the tissue, and then you transplant the lung, it can continue to work over the next few days and deplete the B cells in vivo in the new recipient. And so to mimic that, what we did was, after the lung was perfused, we took tissue and we cultured the tissue in vitro for 24 hours. And then we measured, again, the number of B cells. This time we used a different B cell marker, CD19. And so we did it with the control and the rituximab. And then what we showed is that the percentage of CD19 positive B cells declines, and this is a small number, it's preliminary data, but you can see that both in the lymph node and in the lung tissue, this is after 24 hours in vitro that you continue to have activity of the rituximab. So even after the perfusion's over, the rituximab kind of keeps working and decreasing the number of B cells in the graft. We also looked at these physiological parameters just as a safety assessment to make sure that the rituximab is not causing the lung to to go crazy or anything. So these are, now I don't understand all of these parameters, but our lung guys do this pretty routinely, and you can basically see that regardless of if you get rituximab or control, the physiological parameters remain about the same. So the rituximab doesn't appear to be harming the lungs in any way. So based on this, and we have a few more sets of data to do, and then based on that, we do feel that it would be ready for a pilot safety clinical trial, which I think would need to be multi-center because we'd want to do it in D plus or minus adult organ transplant recipients, which are not that common, but are common enough, but we need to do it in the setting of centers that can do ex vivo. The other piece of really interesting technology that we're working with is using CRISPR in ex vivo organs. So CRISPR, as you know, is a genome editing tool that was originally discovered in prokaryotes, and it consists of a guide RNA that's linked to the Cas9 system. And then basically the guide RNA binds to its complementary target, and you are able to break that DNA by the Cas9 nuclease, and this results in gene inactivation. So the idea would be that you could actually develop a CRISPR with a guide RNA that targets a DNA sequence within the latent CMV genome. So for example, you could target the polymerase gene or the immediate early gene, or any number of critical genes within the virus. So, and this has been done in vitro. People have not used it in an ex vivo system, but people have shown in vitro that you can, in cell lines, you can develop CRISPR-based systems that can target latent herpes viruses. So we developed these 4 CRISPR-based vectors that targeted either human CMV or porcine CMV. And the reason we wanted to also look at porcine CMV is it's just easier to study in an ex vivo model. You don't have to wait for discarded organs to come along. So because we do at least a couple of pig liver and kidneys and lung transplants here a week. So it's relatively much easier to look at. And then the idea would be that you would take the organ ex vivo, so this is an ex vivo kidney, deliver the, in this case we're using a lentiviral CRISPR vector, but you could also use an adenovirus type of vector, and you deliver it during EVLP, and then you measure the outcomes, which would be whether you, first of all, whether you get a transfection of the vector and targeting of the CRISPR RNA to its viral target, and then if you can prevent viral reactivation. So these are experiments that are just ongoing. This is pretty early work right now, but I think it would be pretty neat if you could do this. So the experimental outline in this setting would be either human or porcine EVLP. You deliver the vector at a certain multiplicity of infection versus negative control, and then you look for the outcome of interest, which would be transfection efficiency, target excision, potentially reduced viral load. We're not sure how we're going to exactly look at that. And then you could do immunopathology, as well as you could look for off-target effects, which is one of the concerns with CRISPR. And then the second piece we're looking at with CMV is this fusion peptide. And we've been working with this collaborator in the UK who's developed a fusion peptide. And what it is, it's called F49A FTP. FTP stands for fusion toxin protein, and it targets and kills CMV, human CMV latently infected cells. And what it does is it targets something called US28, which is a viral protein expressed by cells during both lytic and latent CMV infection. And the fusion toxin is conjugated to a Pseudomonas exotoxin. So once the toxin binds to US28, it gets internalized, and the toxin is released, and it kills the cell, basically. And this just shows that both during latent and lytic infection, you get expression of US28. And so if you look at latently infected, for example, progenitors, CD34 myeloid progenitor cells, or latently infected monocytes, they all express US28. So this is the study design for that set of studies. So it's this time we're using CMV positive, seropositive human lungs that are rejected after rejected for transplant. They have research consent. So they're getting clinical EVLP and they're rejected for transplant. And then we deliver the toxin, either the toxin or a control. And then we continue doing EVLP for another 6 hours or as long as the lungs can kind of tolerate it. And then we collect tissue pre and post EVLP as well as perfusate. And we do flow cytometry for CD34, which is the progenitor cells that harbor CMV, and CD14, which is a monocyte marker, which is a common cell type that has latent CMV. And then we do PCR and Western blot for US28, which is the viral protein target for this fusion toxin protein. And then after the ex vivo, what we do is a tissue culture. So we take the tissue, put it in culture, we add some cytokines, and we also induce cell differentiation with MCSF. And the idea is we're trying to promote reactivation of CMV, and then we measure CMV by qPCR and Western blot. And the idea is that if the toxin is working, CMV shouldn't reactivate, but in the controls, CMV should reactivate. And this just shows the flow data. So you can see that this is the baseline flow here. And here we're looking at CD14 percentages. So CD14 is the monocyte marker, and you can see it's 4.46% here. And then after EVLP and treatment with the toxin protein, you can see it goes down to 1% in this flow diagram. And then this is the PCR and the tissue sample for US28 mRNA. So this is the viral protein that's targeted. And you can see this is a relative level of US28. It goes down nicely from baseline to post EVLP, whereas I haven't shown the control, but the control, there was no change. So this is still also very preliminary work. We've done about 3 lungs so far with this toxin protein, and so far the results look pretty promising. And so we're continuing to do this in this discarded human lung model. So in summary, I think this is a pretty exciting opportunity for clinical studies to evaluate the use of infected donors. I think very few people are working on this because you know, one is you need all the EVLP ex vivo platforms, either lung or kidney or liver or whatever. And you also need a really close collaboration amongst the surgeons and the physicians to do this kind of thing. But I think overall there's a substantial opportunity to either increase the donor pool with the Hep C stuff, or to make the organs safer for transplantation with the CMV and EBV stuff. And I think at least for the Hep C now, there's a lot of centers, especially in the US, that have gone ahead and translated to clinical practice using Hep C positive organs. Although our own practice is still just to do that in the setting of these research trials. And I will stop there. And thank you, everyone.